In this case is a 71-year-old male who was referred for an indeterminate biliary stricture. Outside cytology and biopsy again were negative, which again, as we're starting to detect a theme. CT again shows a no mass. In this case, the CA19-9 was only 42, so somewhat elevated, but a little bit not very clear to us as to what was going on. A stent was placed at the outside facility, and the patient was referred for single-operator cholangioscopy. In this case, as you will see, the biopsies that were obtained from the bile duct demonstrated cholangiocarcinoma, so something we would not have expected with a CA19-9 of 42. The patient did undergo a Whipple procedure. Margins were clean, but the patient had 3 lymph nodes that were positive for metastatic disease. A plastic stent was then replaced appropriately with a metal stent. The patient subsequently finished 3 rounds of chemotherapy and remains in remission at 1 year. So again, when we advance the SPY access catheter well into the duct, and then as you'll see here, we're going to advance it beyond the stricture, and then ultimately as we pull back, you start to identify a mass lesion. So different than the first 2 cases that I showed you, now we're actually seeing a mucosally driven mass lesion. So again, very obviously recognizable as something that we don't want to see anywhere in the GI tract. And it's very similar to what we see again in other areas like a mass lesion, we suspect malignancy. However, as you will see in this case, when we talk about strictures cholangiographically, there are fibrotic aspects to the stricture and the malignant aspects to the stricture. And the idea that this tumor could have penetrated the mucosa in one area. And as we pull back, you'll start to see this area, which is much more villous and frond-like. And this is really what we want to see. And this really is an area to target for our SPY forceps. And so what we generally do as we pull back, and I mentioned we take approximately 4 samples, we try to take them in those multiple areas that we feel are most suspicious for malignancy. And here, specifically that villous area and the mass lesion are where we want to target. And that explains why we're able to get the diagnostic yield and the diagnosis of cholangiocarcinoma is made. Again, here you see the SPY forceps clearly entering. Just like any other biopsy, it's important to make sure the assistant or the technician taking the sample also acknowledges to you that you have an adequate piece of tissue. And important to also remember that these are very small samples. One of the important issues with tissue acquisition in this area is going to be how the pathologist interprets it.